Welcome, guys. So, Dr. Mo here with Expat Health, and I wanted to dive into a topic that's of interest of mine because quite a lot of us who end up traveling abroad, we suddenly come into contact with a healthcare system where the barrier to entry might be a lot lower. So, what I mean by that, suddenly you can order any test you want. You can get an MRI, you can get a CT, you can get all sorts of blood tests and everything. And one might think, well, maybe I should just do that. I can now order any blood test I want. And in fact, one place where I see this commonly is in Thailand, where the physicians, with good intentions, are ordering many, many different types of tests. And these tests are essentially meant to be screening tests. For example, in the United States, when you go in, all of us know that when you go to your primary care doctor, you believe that once a year you should be seen and you should get some screening tests. For example, thyroid and a complete blood count, also referred to as like your WBC and your hemoglobin, your H&H, they call it a CBC. And you might get some blood sugar testing, some cholesterol testing, and some other random stuff. And every year maybe it changes. However, what's the science behind it? What's the data behind it? And this is important because if you go to a different healthcare facility where money is really no object, right? Because everything's so cheap, should you get your fractionated PSA levels? Should you get different types of LDL types for your cholesterol? Do those things make a difference, or do they actually create more problems? MRIs, CT scans, ultrasounds. So let's dive into that. Basically, if you take a look at the USPSTF, the US Preventative Service Task Force, also if you look at the NHS, so this is the healthcare system in the UK that essentially recommends what screening tests are beneficial. And now remember, when it comes to the NHS, for the most part, it's a single payer system, so it makes sense for them to screen for certain things that they know they can intervene early, and that early intervention is going to have a great outcome in the future. So this, at least in the US healthcare system, we could say, well, there is some misaligned intentions, misaligned incentives. But in the NHS, for the most part, if they do an intervention, they do it because they believe, if they do a screening test, they know that that early intervention is going to make this person much healthier and it's going to cost the NHS hopefully much less money, but it depends. So let's take a look at the USPS task force. And I'll also start by saying that when it comes to screening, pretty much there's maybe 5 or 6 different things that we need to do that is really going to have a big impact on the health span and lifespan for us in the world. Everything else may not make a big difference. Just because you can catch a certain cancer early, it doesn't mean, unfortunately, that you can treat it. You can get as granular as you like and get monthly MRI tests for your pancreatic cancer. But if that pancreatic cancer is the very aggressive type, even if you catch it early, unfortunately, it may not make a big difference. We haven't advanced that far when it comes to cancers, to certain cancers. Now, you might also catch the type of pancreatic cancer that is so benign that if you didn't catch it, not only would it probably have resolved on its own, we know that there are spontaneous resolutions of many cancers, or it may have progressed so slowly that it would have never caused any issues. However, now that you caught it, you have to intervene with surgery, a Whipple procedure, which is a very complicated procedure, or some other type of surgery which could leave scars, adhesions, maybe chemotherapy and radiation is started, and that creates all sorts of havoc that you otherwise may have not needed. So I know I'm trying not to scare anyone here, but when it comes to this idea of expat health, and we leave our system and we go into a new system where all of this is available, we have to also understand that there are some dangers associated with it. So certain tests like screening for an aneurysm, where the blood vessel in the stomach area gets really wide. This can happen in certain individuals, usually older, who have had a history of smoking or very high blood pressures. It can make sense to do this test because once you do it, there are really good surgical procedures that can help prevent that aneurysm from ever bursting. Screening for depression and anxiety, there are some really good data. So for example, here the USPSTF gives it a B grade. A B grade basically means offer and provide that service. This is a recommendation to us physicians or healthcare providers. B means you should go ahead and provide it. A means you definitely should provide it. Recommendation, USPSTF recommends the service. There is high certainty that the net benefit is substantial. And then there's a C recommendation where it's a little bit like certain individuals will benefit, but probably worth discussing it in depth. And D and I, D basically means there's not enough data, and D means don't recommend it. We've done it, it actually backfires. And many MRIs, whole body MRIs, whole body CTs, unfortunately fall into this category because you catch things for which there isn't a good protocol of what to do next. Now, a very astute physician, a very, very astute physician, somebody who's going to do a lot of research and really take your individual case into consideration, could do a lot with that data. They can get a whole body MRI, whole body CT, know exactly how much radiation they're exposing you to, know exactly what to do with the data from the MRI, know that there are incidental findings that they can either ignore or offer proper testing for. Otherwise, many physicians would say, oh my gosh, let's send you to an oncologist. You got this mass on your thyroid. We did an ultrasound of your thyroid and now we see this mass. What do? We did this brain MRI and now there's a little lump there. So now we got to send you to a neurosurgeon. I don't know what to do with it. And that can become problematic. So they have a good grading system, and the majority of everything that I have here on this list is A and B. So we got screening for depression and anxiety, of course, and I talked about mental health for on my expat health channel. When you go abroad, there are certain things that change immediately that can put us into a lot of stress. Screening for breast cancer, for example. So we got breast cancer screening through mammography. That can be beneficial, though there are some, even there is some data to show that maybe we're catching very slow growing cancers that wouldn't have caused any problems, but we're not making a big difference in the fast growing cancers. I'm not saying don't get a mammogram, but just because there is screening recommendations here, it does not mean that it is enough. Certain women will benefit a lot more from not only a mammogram, but also an ultrasound and an MRI. And unfortunately, that is not captured in these recommendations. For those, you really need to have a very competent, astute physician who's researched this, who understands this, and knows for which women, based on their risk factors, obesity, smoking, family history, whether they need further testing and not just a mammogram, where you might see some calcification, but never as good as you might see with certain MRI studies. So we got breast cancer screening in different age groups, maybe from age 40 and up or from age 50 and up. So those can vary, but it is certainly recommended to do mammography. For women with BRCA related cancer histories or family histories, there's other recommendations. Cervical cancer is one of those cancers. It is slow growing, but we have amazing treatments for it. Cervical cancer, where the cervix at the end of the vagina can become cancerous, right? The cervix can develop cancerous cells. It grows very slowly. We can check very, very slowly as those cancers grow, treat it, get rid of it, and you'll never have any issues. That's amazing, right? And that's the same with colon cancer. In fact, when we do a colonoscopy and we catch a small polyp, those polyps are what eventually going to turn into cancer. All cancers came from a polyp when it comes to common colon cancers. And so if we can remove that polyp, we definitely will prevent you. Well, I will say that if that polyp was going to become a cancer, we definitely would have prevented you from getting cancer. Chlamydia, gonorrhea, syphilis, HIV, Hep C, these are so important to screen for. If you are sexually active in this day and age, because we don't know where our partner may have been, it just makes sense from time to time to do some STD testing. We talked about colorectal cancer screening. Now it's interesting because in the US, a colonoscopy is recommended, but here in the NHS, their guideline is a little bit different. So they go through many different things like infectious disease screening and different type of imaging modalities. But when it comes to colon cancer, I'll find it down here for you guys in just a little bit. They actually recommend just a stool test, which is also quite effective. But in the US, and I think from the data that I've come across, if you really, really want to be accurate, it might make sense to do a colonoscopy where you have a camera inserted into the colon, which is quite cheap, even if you paid cash in the US, somewhere around $1,500. And if you did it abroad, as little as $300 to $500. We talked about depression, anxiety, and suicide, gestational diabetes for women who are pregnant, talking to people about guns, if there's guns in the house, and kids, of course. Believe it or not, those are recommendations that a physician should make. Those are discussions that we should have with our patients. I don't always do it. I'm just as guilty, but for the most part, I hope that I do. Here's a hepatitis C one. Now, in the past decade or so, we've developed a cure for hepatitis C. Who would have thought? We never thought we would. And hepatitis C, for anybody between the age of 18 and 79, at least once in your lifetime, you should be checked for hepatitis C. It's pretty rare to catch it, but some people with blood transfusions, IV drug use, and other reasons, people who work in healthcare and gotten pricked with a needle, they can get that, unfortunately. HIV, I mean, this day and age, if you get HIV, we can treat it and you can live as long as anybody else. You'll die from something else, but not HIV. We have really good medication. So it makes sense to screen for it. It makes a lot of sense to screen for it because we can treat it. Tuberculosis, latent tuberculosis, of course, that means tuberculosis that is at rest. And we want to screen for that because if we can treat it now when you're healthy, God forbid if you ever get unhealthy, that tuberculosis activates, it's going to be much tougher to treat that. Here's one interesting one. So this is called a low-dose computed tomography. So basically a low-dose CT for lung cancer. That is a good thing to do. But doing a CT scan of your entire body looking for cancer doesn't make as much sense because for lung cancer screening, if we do a low-dose CT scan and we just remove that part, especially in people who have smoked at least 15 years, it makes sense because we can remove it and chances are that's going to be such a slow-growing cancer. It's not going to kill you. But for other cancers, like pancreatic cancer, for example, that I talked about, it's not the same. For parotid cancers and other types, even catching it early may not make a difference. So other tests we talked about. Okay, so osteoporosis, checking somebody for thinning of the bone. This is where it gets a little bit more nuanced because I could check you, let's say, Asian woman, classic type that would develop osteoporosis or osteopenia early and have a high risk of fractures. Now, let's say I catch it. What do I do about it? Well, unfortunately, just giving you bisphosphonates, which is a medication that will thicken the bone, let's just say, doesn't seem to help that much. So really what's going to help is a dietary change and resistance training. And the question is, for me as a physician, if I catch osteoporosis in one of my female patients, I will ask her before even doing the screening, do you think you would start a resistance training exercise and, dietary change if we do this, or you have no desire to? Oh, no, I'm not changing my routine. I'm not changing my lifestyle in any shape or form. Great, so let's not do the test. It's a waste of your time. It's just going to give you anxiety that now you have osteoporosis and you're going to get that fracture, maybe never, or probably eventually. And looking back, you wouldn't have done anything anyway. It sounds harsh to say it like this, but this saves a lot of headache and saves a lot of positive results, false positive results that then give us a lot of anxiety. So doing any kind of testing should always be done with the patient in mind. Preventing dental caries, so dental issues, cavities in children, sexually transmitted infections, skin cancer prevention by putting on sunscreen and other things. Now, in my practice, with my own digital nomad health practice, we have a very different way of approaching skin cancer, and I will maybe go into that in future topics, but we definitely don't follow standard guidelines when it comes to that. And of course, checking somebody for their 10-year risk of coronary artery disease, also not something that we do in my practice. The 10-year risk only starts at age 40, which doesn't make sense. Most of us develop coronary artery disease starting in our teens. And so for anybody who's at risk, the screening protocol and paradigm has to be much more aggressive because, unfortunately, heart disease is still the number one killer. And for that reason, we have to be very aggressive with it. Smoking cessation, so intervention, obesity, what to recommend. Now, of course, right now, semaglutide is a medication that's all the hype. And so, hey, maybe everybody should be on semaglutide. And so the discussion of obesity and being overweight is front and center. So that's a little bit about the USPSTF task force and their recommendation. As you can see, a lot of the other type of tests like homocysteine levels and uric acid levels and your WBC and your hemoglobin, it's not on here. And there's good reason why. It doesn't mean that we shouldn't do it. It just means that doing it may not really be all that beneficial. And of course, that was only A and B. I didn't talk about C, recommendations. That's for another topic. And I wanted to also just give you guys a quick rundown of the NHS one. Let's start at the very top. It's very simple, very straightforward. They explain what the screening is. They have really good tutorials. Unlike the American system, they are all about patient empowerment and patient education. So really taking their little YouTube video courses, taking their educational courses, screening timelines, what women need, what men need. I think these are great things. And you can click on here and check out the YouTube channel. Screening for newborns, screening for diabetic eye issues. So obviously this is much more condensed because there is also not a lot that can be done. I would even go as far as to say that the American USPSTF is a little bit too aggressive. It's offering way too many screening things, and we can get lost in that because just because I screen for something doesn't mean my patient's going to be able to do something different in their lifestyle that's going to change the outcome, or even afford the medication that I'm going to prescribe them, or take the medication, or be able to tolerate the side effects of the medication. So the bowel cancer screening one is interesting. They really recommend that you start at age 60 and do a home test every 2 years. In the US, it starts much younger, 40, 45, and you do a colonoscopy every 10 years, a sigmoidoscopy every 5, or like, a stool test every year. So a little bit different, very similar as far as the abdominal aortic aneurysm that we talked about. And then I'll include the links here for you guys to take a look at it later. In summary, I will say that don't initially get too caught up with doing a bunch of screening tests. Just because it is available, it doesn't mean that it's going to make a difference in your outcome. For example, I'll give you guys a good personal situation here. I'm in my 40s and I would be due for a colon cancer screening. Why haven't I done it yet? Number one, I'm low risk for colon cancer. Now, some people will say that those people who eat a lot of meat or processed meats have a much higher colon cancer test. That's inaccurate. The percentage compared to the baseline is a little bit higher, but it's quite negligible. So even if you have I don't even eat much meat, but if you have a high animal protein diet intake, I still don't think necessarily that would be a big risk factor, but obesity, family history, smoking, and certain other things which always contribute to cancers can be. They really can be major contributors and increase your risk, and for those individuals it might make sense. Another thing to consider is there is still a 1% chance of perforation. So if I went and got a colonoscopy and somebody perforated my colon and I might need a surgery to correct that, I might need an ostomy bag, colostomy bag as they call it, then that would be a major complication for me, and I don't know if the risks would outweigh the benefits. And if they did find a polyp, just because they found a polyp, it doesn't mean that that polyp was going to become the kind of cancer that would have killed me one day. Many polyps may disappear. Some polyps may never become hyperplastic or precancerous or cancerous. And some cancers will be so slow growing that at the age of 45, I'll probably die from a heart attack or car accident or suicide or old age before that cancer ever becomes anything. And same thing with PSA. Classically for men, we get PSA testing. There is really no data whatsoever to show that if you do a PSA testing, or even when the physician does a rectal exam, a digital rectal exam with a finger, and with the tip we feel the prostate to see if there is any kind of growth on it. Doing all of that, catching that cancer, it doesn't mean that you're not going to die from something else. And the way we explain that in the scientific community, we ask, if I do a colon cancer screening on a patient, will I decrease their all-cause mortality, which is the very top line for me, the most important question to ask? The second question, will we reduce colon cancer-related deaths? When it comes to colon cancer, the data right now shows we definitely decrease the colon cancer-related deaths. So fewer people will die of colon cancer-related deaths, colon cancer-related causes, than of other causes if we intervene with a colonoscopy. But the all-cause mortality, meaning that, so will my lifespan be increased? No. So right now the data that I have looked up, and there's more data coming, in fact, some more stuff is getting published in 2023, doing a colonoscopy will not change your end date, if that makes sense. The expiration date does not seem to change. It probably means that we are likely catching cancers in people who are having other issues that lead to other diseases that are killing them anyway. So just because you decrease this factor, it doesn't make a big difference. Hope that makes sense. I know it's complicated. It took me many years to really understand the difference between saying, oh, look how many polyps we caught, therefore that colonoscopy was successful, versus, well, that's not what we're measuring. I want to know if I'm going to live longer. Oh, well, we don't know that. We haven't done enough studies to know that. We just know that we caught a lot of polyps, and polyps turn into cancer, therefore decreasing the number of polyps in your colon makes sense. That's not the way science works. That's not the way medicine works. Hope this is helpful. Hope it's not confusing. If you guys have any questions, leave the comments below. Let me know what else you want to hear about and read about, and I'm happy to record some other videos. Take care.